conference will now be recorded. This conference is no longer being recorded.
Go ahead.
So, and he called Bill Franklin today and reamed him a new asshole because he said he never knew that the group was being recorded, and now he finds himself on YouTube, and his 92-year-old mother doesn't know that he's sick. Well, I think that I know I told him, just like John was about to tell you, we know that the group just started, that it says it at the beginning of the group. So we just do want to be really sure that everybody knows, especially newbies, that we do record these groups, and we do it for very good reason, because a lot of people listen to this, some of the people who attend, some of the people who don't attend, and we do record the groups. So please don't be coming to us later and saying we didn't know. And of course, if you read the reports, you'll find it. And I saw a message from Keith that it is not Keith L. It's a different Keith, and he's a newbie. John, did you see that?
I see it. All right, I'm going to start the recording, and once I do, you'll see there's another big red button that says we're recording.
This conference will now be recorded.
Hello, everybody. It's John Antonucci. This is AnCan's high-risk metastatic recurrent prostate cancer discussion group. I have a couple of other moderators backing me up here. Jim Marshall, Rick Davis, David Muslin. Who did I miss? Anybody else? And we just want to make a brief disclaimer that we are not going to be giving medical advice, but sharing our experiences together. We will exchange a lot of information for you to take back to your doctors. I want to thank Bayer, Johnson & Johnson, Myriad Genetics, Telix, Blue Earth Diagnostics, Foundation Medicine, and Novartis for sponsoring us and helping us keep the lights on so that we can continue to have this wonderful group. I am going to start out. I'm going to start out today's group by getting to know a new member, Bob Young. Bob,
John, just before you start, I just want to, on behalf of all of us at AnCan, echo what Bob Schwartz said in the chat window and wish all our veterans who are here a very happy Veterans Day. Bill Franklin sent out a beautiful message this morning, touching. It's a very special day for Veterans Day this year, 11/11. 11, I guess Veterans Day is always 11/11, but it's good for us. I guess it's a special day for us to have our meeting on 11/11. That's what I was trying to say. And my thoughts on 11/11 were in the meeting this week. So there we go, and we just added another moderator to our ranks. Dr. John Len just arrived.
And Len Sierra, welcome, Len. Did you want to bring up anything tonight, Len? Caught him unaware. Oh, okay. Michael Wolf, did you just come in?
Yes.
Yes, I just came in.
Okay. Do you want to bring up anything tonight, Michael?
No, I don't have anything. Thank you. Still waiting for my appointment. Thanks.
Okay. Very good.
Hey,
back
John,
to...
this is Gary. I came in at 10 after. I don't need to bring anything up either. Thank you.
Okay, Gary. Very good. Bob. How old are you, Bob?
73.
Where do you live?
Los Angeles.
How'd you hear about AnCan?
Heard about it from my friend in the neighborhood here, Jerry Hans, who was a member, but he was a member of the lower risk group. I think he was at a 3+4 or 4+3, but he told me about AnCan. And so I watched your meeting last week and it seemed very interesting to me. And so I'm happy to join you.
Very good. Welcome. Are
Thank
you married?
Yes.
Single?
Married.
When did you get diagnosed, Bob?
I had the MRI on October 12th, with which looked suspicious, but that had followed a PSA reading on September 2nd of 22, which was way up from my reading a year and a half earlier of 2. So MRI on October 12th, biopsy transperineal on October 24th, and I have
2022.
Yeah, no, this of 2025 this year.
So you had a PSA make a big jump in 2022, but you didn't
No,
get
I'm sorry.
your MRI?
I'm sorry. I may have said that wrong. I had a PSA reading on September 2nd of this year of 22, and then another reading a couple of weeks later of 28.
Gotcha.
And,
okay. Okay. So your most recent, well, you went to 22 and then you went to 28.
That's right.
And then in October you got your MRI.
And the biopsy.
What did that show?
The MRI showed a suspicious section on one side of the prostate, and my doctor at UCLA said, let's do a transperineal biopsy, which we did 12 days later, and that confirmed localized, not local, how would you, I don't know how you say this, very specific area on the right side of the prostate that he said definitely has cancer. He gave me, the Gleason score was 4+5.
Okay. Did your MRI happen to pick up also that same lesion?
It seemed to, yes, it seemed to pick up that area. That was why the doctor went specifically for that area in most of his tissue core samples.
And just out of curiosity, did the MRI identify that as a PIRADS 5?
No.
It didn't.
No.
What it
No, I mean, I don't know. I'll have to dig up the MRI report. I don't think he even sent me. I got the biopsy report. I don't think I even have the MRI report.
Okay. Well, since we know exactly what's
Yeah.
going on, it's not that important. But I'm always curious about how well the PIRADS score correlates with the Gleason score that we get afterwards. Okay. So we're back to last month now, and you have a lesion in the right side on biopsy, graded as a 4+5. And tell us some other details about your biopsy, if you remember, like how many cores did you get? And
it looks, I'm holding it in my hand, the biopsy report. It appears that there are 17 cores, I think. And there are they are marked from A to Q. They are labeled from letter A to letter Q. And they are labeled, right this, right that, left this, left that. And then the last 3 are called target 1-1, target 1-2, target 1-3. Not sure what the difference is there.
And those was the grade 5 pathology in the target or outside the target?
Yeah, it was grade 4+5. 4+5 equals 9 in each of those 3 targets.
Yeah. Oh, those targets must have been picked out on the MRI. And look at how well the MRI, whatever the PIRADS score was, look at how well the MRI got the urologist to pick out that really hot area of grade 5 pathology.
Yeah.
So the MRI did well. How many cores altogether had cancer in them, no matter what the score was?
It looks like 5.
5 out of 17.
Mhm.
3 of them picked out by the MRI. That's really
Yes.
nice to hear.
Mhm.
And that
And
shows
one of the 5 is a 3+3. One is a 4+4, and 3 of them are 4+5s.
Yeah.
So
Yeah. This
yes,
is why we really like for people to find their way to MRA fusion guided perineal biopsies, which most of us in this room, they really weren't even doing them yet when we got diagnosed. So after that happened, have you had a busy month, or are you just waiting for discussions about treatment planning?
we've had a discussion, me and my family, with our doctor, Dr. Donin at UCLA.
Dr. Who?
Donin, Donin, Nicholas Donin, UCLA. He's a urological oncologist, or a
Okay.
oncological urologist. He's a urologist who also got an additional degree in oncology. He suggested that I meet with a radiologist. I have an appointment with a radiological oncologist, Dr. Kishan at UCLA, in a couple of weeks. I have an appointment for a second opinion with another urological oncologist in a week. I am waiting to get an appointment for a PET scan. I really, really want to get the PET scan to find out about possible metastasis. But it takes a long time at UCLA to get it scheduled. It takes like 5 weeks to get it scheduled.
When is it scheduled? Do you
Yes.
even have a date?
Yes, I have a date, December 5th, and I'm trying to beat that by going to a hospital in Pasadena and see if I can get an earlier date in Pasadena.
Okay. So at this point, no treatment at all yet?
No.
Okay. Okay. Are you a veteran?
No.
Do you have any family history of cancer?
Yes.
Tell us about it.
Sure. On my mother's side, mother had breast cancer twice. Her sister, my aunt, had esophageal cancer and died of that. Also on my mother's side, her brother had stomach cancer. So all 3 siblings on my mother's side had cancer. Only one of them did the cancer kill. The other 2 basically outlived the breast and the stomach cancer. On my father's side, my father's twin brother had bladder cancer.
I don't have to tell you after hearing that how important genetic testing is going to be for your case. Have you had it yet?
No, not yet. No.
Okay. There's a couple of things for you to know. There's 2 kinds of genetic testing. One is the kind where your family genes that you pass on from your parents and your uncles and aunts and pass down to you and to your children, those genes, those we call germline testing.
Germline, okay.
Germline, and you might as well get that right away. Rick will probably put something in the chat. If you can find the chat, it's in the upper right, those 2 square boxes, where you can get a free germline testing under the PROMISE study.
Yes, I saw that from Rick. Put that in the chat in the recorded group last week that I saw.
Okay. So it would be good for you to get that.
And that's you send away and they send you a kit and you send them a saliva sample or something?
Yeah.
Okay, fine.
Yep. And just for your future reference, since you're a high-risk person, there's another kind of testing that we call somatic testing, where they actually test the cancer tissue itself. So you would have Dr. Doman send your tissue samples off to a lab, and they would see whether there's anything there. Now, whatever you've inherited is probably also in the somatic test, but there may even be something new and unique. We don't worry about it quite so much in people who are just newly diagnosed, but if the PET scan finds a metastasis, we'll probably try to make really sure that you get the somatic test as well. Or if the germline test shows up something really interesting, the topic may come up again.
Got it.
How's your medical health?
Generally very good. High blood pressure. I have had cancer myself once before, malignant melanoma in 1998, so 27 years ago.
And were you treated with surgery plus chemotherapy for that, or what?
Surgery only.
Immunology?
Surgery only, using a sentinel node biopsy technique. They extracted, they took out the tumor in my back and took out 3 lymph nodes under my right arm. The lymph nodes were all clean. And so the doctor determined that for that moment, I was clear. And
okay.
So I was, basically.
Okay, and it was a long time ago, so you probably, in fact, were clear.
Mm-hmm.
Okay. So you have high blood pressure, what well controlled on medicines?
Well, very well controlled.
Okay.
Not a problem.
You exercise, you eat well, or you a couch potato, or do you eat at McDonald's every day? I'm looking for.
I try to eat healthy. My wife sees to that, and I exercise. I walk every day, or walk on the treadmill, or use a rowing machine, or something like that. Yeah.
Okay. Okay, you're very much in the spot that I was in a few years ago, and we've got some more information coming in. You will probably, well, no, you're going to have a discussion pretty soon. You're, because of that Gleason 9 score, you're going to be maybe treated a little bit more proactively than somebody with a low Gleason score. So even if you don't have metastases, there might be some treatment. And
yes, I'm lucky to have 5 or 6 men in the neighborhood here who have had prostate cancer in the last 10 years and who have had all different treatments. A couple of them have had radical prostatectomy, and all of them are alive. And a couple of them have had radiation, beam radiation or targeted radiation, and a couple of them have had androgen therapy. So I've had talked to a number of people who've had all different treatments. So I'm kind of exploring all of them. Although my surgeon, my primary doctor, has said he feels that in my situation, surgery is, in his opinion, the best option, but he is sending me to a radiologist.
Yeah, good. We'd like you to talk to, not really a radiologist, but really a radiation oncologist.
That's who it is. Yes, radiation oncologist. That is correct.
And we've been just delighted with the progress in radiation oncology in the last number of years. So take that option, I think, quite seriously. And after you meet with your consultants, if you like this group, come back and we'll keep discussing with you all the way along. What questions do you have at this almost critical point in your cancer journey? Because you're going to be making some major decisions between now and Christmas.
Yeah, those are the questions. I mean, I have to get the PET scan done. If there is metastasis, then I'm assuming that I'm up for one of a number of different radiation therapies, plus possibly testosterone reduction. And if it's not metastasized, then I have to decide between surgery, a prostatectomy, which a couple of my friends have done, and they've come through it very well. It scared me initially, but it doesn't scare me too much now. And radiation, which seems to work very well, although from what people have told me, the side effects are kind of really unpleasant, but
The side effects of
radiation.
surgery are unpleasant, as well as the side effects of radiation, as well as the side effects of hormone therapy.
Yeah.
But you've got a lot of buddies that have been through it, and you've got a lot of people in this room that can share their experiences.
Yeah, that's what I'm looking for, is to hear what other people have been through and done and how they felt about it. Yeah.
Let's do that right now. Let me call on the group to see if anyone would like to speak to Bob about their own experience.
Yeah, so John, Dr. John, I want to bring something up real important. We're not doctors here, but on the basis of my own peer experience, I would strongly disagree with your Dr. Donen.
Mm-hmm.
We would encourage you to run the Memorial Sloan Kettering nomogram. I've put the link in the chat window for you. The pre-radical prostatectomy version of that, and that's
what is that?
That's going to I'm going to tell you, that's going to give you an idea as to how successful surgery alone would be. In other words, based on your disease demographics, which 5 out of 17 cores were positive, a PSA of 28, highest Gleason score of 4+5, how likely it is that surgery alone is going to be sufficient for you, or whether you would need radiation as well. And that, I think, for a 4+5 person is probably the most important test they can run. Now, there are pros and cons, and Dr. Donen may not like the nomograms. We happen to think they're very valuable. They have their fallibilities, but that database at Memorial Sloan Kettering is constantly being upgraded, and it's constantly being changed. And my guess is, without running those numbers, and you can even run them whilst we're on the call right now, my guess is that you're not going to have much more than a 20% likelihood that surgery alone will be sufficient for you.
To be fair, Dr. Donen told me on the phone call, he said, I think surgery is a good option for you. He said, but you should understand that there is a 50% likelihood of cancer recurrence after the surgery in succeeding years.
Yeah,
so he was very clear about that.
I would say 50% was underselling it. I would say, based on the nomogram, you're probably going to see it's more likely to be around 80%. And so you then have to decide, do I want to put myself through an extra set of comorbidities for the surgery, or would I prefer just to live with the radiation and the hormone therapy initially?
What are the comorbidities of surgery that you're speaking about?
Well, the comorbidities of surgery are going to be incontinence, mainly incontinence and erectile dysfunction. Right. Now, there may be others as well. Okay. We see a fair number of people, but not that many, who have hernia issues. A lot of it depends on how you recover, but I think the main ones would be, you're guaranteed incontinence until you become continent, and you may be guaranteed erectile dysfunction. But I think the big issues are for you to decide, well, do I want to do the surgery and then see if that's enough, or do I want to do radiation and hormone therapy and forego the surgery? And I think this will allow you to make the mistake. I also would not, if it were me, I wouldn't be getting a second opinion from another surgeon at least until after the PSMA. I don't think you're going to learn a heck of a lot more with the second opinion now. I think you need more information.
PSMA, that's the PET scan?
Yes.
Okay, got it. Understood. Yes.
Okay. There are several different types of PET scans. So the PET scan you're getting is a PSMA PET scan. And that's going to give you a good idea as to whether the cancer is outside the gland.
Okay. I understand. I just didn't understand the term comorbidity, and you're basically talking about side effects, essentially. Or yeah. Okay.
Yes. Sorry, I should have.
Understand. No.
My bad. All right. So that's what I have to say. And John, I'm also. I know you got a hell of a lot of people with questions today, and I know you got another newbie. So I just want to bear that in mind.
Okay, let's see. I think Herb has his hand. Oh no, Herb, did you have your hand up? Do that gesture again. I didn't see you.
No, I was just going to talk about the recurrence after prostatectomy, but you guys covered it pretty well. So
yeah,
I've got it.
Yeah, I think you'll be pretty disappointed after you run that nomogram, but we'll see. Jeff, what do you got?
Well, while he discussed your Gleason score, there are other issues with the biopsy that can be very aggressive. And the question is, did your biopsy show intraductal or cribriform or seminal vesicle invasion or extraprostatic extensions or extracapillary extensions? All of those can make the cancer more aggressive, show that it's come outside of the prostate. There's just some things to consider that you should check your biopsy and look for.
Cribriform, I see.
Intraductal.
Intraductal, right?
Mm-hmm. Seminal vesicle invasion.
Right.
And EPE or ECE, which are extraprostatic extensions and extracapillary extensions. And those are just, and PIN is another thing. But that isn't as aggressive. At least I know most of the people I find have that. It's including me.
Jeff, FYI, it's extracapsular extension, not extracapillary extension.
Thanks.
Same thing, basically the same thing as the EP. But did you say? Do you have cribriform? Because if you do, I want to point out something really important to you.
It says cribriform present on 2 of the target.
Okay, so did you get? Are you signed up for our reminder yet, Bob, or not?
I don't even know what the reminder is.
Okay, so each week we send out, before the meeting, we send out a reminder, but it's really more of a newsletter.
Oh, okay.
Do we have your email? Or if not, if you can put it in the chat window and we'll make sure you get signed up. Now, and sure, I would like to send you, I'd like to send you this week's reminder, because there was a very, very important piece of research that came out last week. It's a little incomplete, but you'll get the gist of it.
Sure.
And the gist was that for men with cribriform disease, and they don't really get into what type of cribriform, because there's lots of different types of cribriform, but for men with cribriform disease who had surgery, 25% of them went on to become metastatic. For men with cribriform disease who had radiation and hormone therapy, 8% of them went on to be metastatic. Now, there's a lot of questions, and it's a bit of a broad brush, and we don't have all the information. It comes from the PROTECT study, which was done between 2009 and 2016, and this is a follow-up to the original PROTECT. But what it's basically telling us is if you're a cribriform guy, there's very good reason for you to choose radiation rather than surgery. And thank you for your email. I will note it, and after the meeting, I'll send it to you. You can follow it up, and you can take this research along to show Dr. Donan, see what he makes of it. But
What was the percentage after surgery?
25% of men from this sample.
Yeah, got it. From
Now,
that
it's
sample.
not a huge sample. It wasn't a big sample in the first place. This was a study that was done originally to compare surgery to radiation. It wasn't a huge study originally, but these are pretty eye-opening numbers. And we just want to, this is what we do here. We just want to put them in front of you, and then you can do with them what you will, and we will definitely send these on to you afterwards. Or I may even send them to you. If I get a breather, I'll send them to you during the meeting. They're easy to send on. Most of the guys have seen it. Well, I shouldn't say that. Most of the guys have received it. How many of them have read it? I don't know. But
Any other comments for Bob or questions from Bob? Okay, I have I'm going to go on to another new guy if he managed to get back on here. Keith, Keith, are you a new guy? Can you unmute? There you go. I can't hear you, Keith. I don't know if you're speaking or not.
okay, so a couple of things, Keith. One is you can run up to the cogwheel in the top right and click on it and see if you've got the right microphone selected, because you might not have the correct microphone selected. Try that first of all, and then talk to us and see if it's a problem with selecting the right microphone. If not, I've pinned go to technical help in the chat window, and we would suggest you call go to technical and tell them you can't get your microphone and you can't get your camera to work, because it gets above our pay grade if we can't solve it with. The only other thing to do is to go out and come back in again. That does sometimes work. What I'd suggest is see if you can troubleshoot with these guys. Come on back in. If we can hear you, maybe we can take you as a newbie a little bit later. If not, we will. Len, you'll take Keith as a priority next week. Is that right, Mr. Sierra? You're muted.
Yes, sir. I'd be happy to do that.
Okay, Keith. So 2 options for you. Go out and go in, or call 877-852-7011. I think that
Okay,
number is right.
Keith will keep an eye out for you. And I'll start going down my list of regulars now. Dan, you were a little bit unsure about whether you wanted to be bring up something or not. I put you as a question mark.
Yeah, I did start my treatment with Dr. McHugh. He ordered some blood testing, and my PSA went to 0.4. It was 0.5 last time. And one thing on the blood test, it said the alkaline phosphate was 129, and I kind of looked that up. I still didn't quite understand, so I was wondering if somebody give me some insight on that.
That's not really a very high, scary number. Alkaline phosphatase is a protein. It's an enzyme. It can be made by various organs like bone and liver, and it gives an indication about whether there might be disease in those particular organs. It might, for our purposes, we usually don't see much in the way of alkaline phosphatase except for when people have bone disease, and I think you're too early in the game for that. What's the normal range on that particular reading? Goes up to like 125 or something?
Yeah, 147 to 123.
123. Okay. I think that you can disregard that until your doctor decides to repeat it next time.
Okay.
Unless there's a pattern of other liver tests that are abnormal or things like that.
Okay. And also too, I actually haven't broke my ties with my previous oncologist because I have to have a CAT scan, which is Friday. When I went to as a follow-up, I had a sarcoma on my left chest. They saw a dark spot on my lungs, and so they wanted me to check with my oncologist here, have a CAT scan, and just to verify it's not cancer. So after I have that CAT scan, then I'll officially break ties with him. I'm just concerned about what that, that dark spot on the CAT scan could be. They said maybe it was like a pneumo something, and so I'm just hoping that it is.
You're having a CAT scan of what part of your body?
On my chest.
Chest. Oh, okay. So this has nothing to do with the old sarcoma or anything, right?
No.
Okay.
And she said they saw it on my lungs, so.
Yeah. Okay. Yeah, many people have nodules on their lungs. The vast majority of them are benign, but they're going to work it up. And if it looks benign, they'll just repeat it at intervals.
Okay.
If it looks irregular in any way, then you might get a more detailed test or even a biopsy if it looks suspicious.
Okay.
And Dan, everything's fine with the prednisone, no problems. You restarted it, and you're all good with the prednisone.
Matter of fact, I regained most of my energy. Of course, I've been exercising and swimming. I gained most of my exercise. My appetite's good. My weight's good. So
Okay.
yeah.
Okay.
Good.
All I can say is you dodged a bullet. You're a very lucky guy.
You're blessed.
You are
Yeah.
blessed. You are blessed.
Yeah.
Truly.
Yeah. Yeah.
Okay,
And
John.
thank you guys,
Okay.
because had I not, ran into you guys, it might have been a different story.
Yeah.
Okay. Frank, where are you, Frank? You still here?
Yes, sir.
Oh, you went from the top all the way to the bottom of my screen. Okay, Frank, tell us what's going on. You said something about, well, go ahead.
All right, so last Monday at 2 o'clock, I started passing blood through my urine,
Yeah.
and I came to the group and I left, and by Tuesday morning it was clogged, and I went to the emergency room and got a catheter. It didn't stop bleeding. Normally I would just push some clots out in urine and then just drink a lot of fluids and it would clear up. By Wednesday, they removed the small catheter and put a big catheter in, and flushed. I was constantly getting my bladder flushed out with all the blood clots and urine. And blood. So I had the catheter bag on until Friday morning. By Thursday, it started turning to regular urine, and they removed the catheter Friday and scoped the inside of my bladder. And the doctor said that the bladder was just kind of real beat up on the inside, probably from the radiation and from the catheter being in there. So they removed the catheter. Today's Wednesday. I'm just pushing fluid still. This afternoon, I was moving motorcycles around in my garage and lifting transmissions and stuff. So, I'm recovered, but that's just honestly where I'm at.
What's the color of your urine today?
Oh, it's like clear white. I drink so much water. Yeah, it's clear white.
Okay.
I'll tell you something. I'll tell you something. Dr. Paul is looking up to the heavens where I see him. I'm watching him in the screen, and he's looking up to the heavens when you say that you're lifting transmissions 2 days after you got a catheter out. So I don't know if Dr. Paul wants to say anything, but I think we should give
I got it
him
out Friday.
space.
Yeah, I
Oh,
got it out
Friday.
Friday. Today's
Oh,
Tuesday, so
oh,
yeah.
Well,
Friday.
that's
Okay.
different.
Okay, that's different, right? Go ahead, Dr. Paul. Would you like to comment?
Well, yeah, I'd advise taking it easy for 7 to 10 days and not increase your intravascular pressure, which will tax the clot or I will say the sealing of your vessels. And just a quick question, how long ago was your radiation?
I mean, I've had all kinds of pelvic radiation. Right now, I'm on Pluvicto. I already did 6 treatments,
No,
and I did a redo.
Frank, he means your radiation. When was that?
I'm sorry, to your to your prostate. How long ago was that?
That had to be right after I got my prostate out. So that was probably 2018, 2019. And then I had all kinds of radiation where they were radiating the metastasis on my bones, and
right.
you know So yeah, I've had a lot of radiation, but the Pluvicto. Go ahead.
Okay, wait a second, Frank. Let's hear what he's a urologist I'm curious what he might have to say about a 7-year gap between your radiation and the development of your radiation cystitis. So,
well, yes, radiation cystitis is a benign inflammation, irritation, aggravation of the bladder mucosa from radiation, which takes a while to cause the damage. So it's kind of counterintuitive in a way. Surgery, you have surgery and you recover, and with time, things get better. With radiation, sometimes the side effects often appear a long ways down the road. And one of the problematic issues is a new malignancy in the bladder, potentially caused by radiation. Now, I don't want to alarm you, but I think if all the bleeding resolves, which it has, and your bladder looked beat up, which it has the right to be with the catheter in, that it shouldn't just be forgotten that you had this episode, and that whether it's a month or 2 months down the line, what we call a cytology of urine and another look in your bladder to be sure that it's getting better and that there is no, we'll say, reaction in a malignant fashion in the bladder tissue. So that's just a warning for everybody who's had radiation in the distant past and suddenly develops either microscopic or gross, which means you can see it or you can't, bleeding.
Thank you very much.
Frank, do you happen to be on anticoagulants or aspirin?
No, I was on small aspirin, but I stopped taking that just
Okay,
like
very
last
good.
week.
I see a hand is raised. Alan M.
Yeah, hi. I can relate, Frank, to your situation because I had radiation cystitis pretty bad. And it was 6 years after my radiation. I had one episode, just like you had. I ended up in the emergency room. They did the same procedure as you and flushed it out. And I thought I was good. But I wasn't good. And ultimately, it recurred every time I had a strain for a bowel movement or lifted something, and I was in the hospital half a dozen times monthly subsequent to that, even though I had a few months where I had no issue after the first episode. And ultimately, I needed hyperbaric oxygen treatment, and I won't go into it now, but you can read about that. It's often curative, whereas many other treatments are not. Hopefully, you won't get down that road. The only guidance I would give you is that for a period of time, I would not travel and get yourself in a situation where you're not near a hospital. So if you think you're going on a 6-hour plane ride, I'd be very cautious because, as you well know, it's not easy to deal with that situation when you're 30,000 feet over the water. Right? I'm happy to talk to you on the side if you care to do that.
I'd like to ask Alan or Paul, is there, if hyperbaric oxygen is a treatment, is there any negative consequences of spending 4 hours at high altitudes at 0.8 atmosphere or whatever it is up in an airplane? Either you guys know?
Yeah, I can tell you there's at least, I can tell you off the top of my head, there are 2 issues, both I would say minor. One is in the short term, your vision will change a bit, meaning, what was clear is a little blurry and all, only because the shape of your eyeball changes a little, but it does change back when you're done with your treatment. And I had 20 sessions, roughly 2.5 hours each time. And then I had another 50 sessions, 6 months later. So that's one thing. Cataracts will advance and grow more readily. And my cataracts that I had already advanced like that. And then I needed surgery a little bit ahead of schedule. And then in my case, I couldn't take the change in pressure with my ears. I always had a eustachian tube dysfunction. And so my ENT put in ear tubes, and that made the procedure literally painless. Other than that, I'm not aware of any long-term issues. And
Let
also,
me thank you, Alan. Let me just ask Paul if airplane travel is safe for somebody like this.
Yeah, I'm not aware of the reduced oxygen that you are exposed to, because as I understand, you're pressurized to about 8,000 feet when you're in an airplane. You're not pressurized at sea level. But I'm not aware of that being an instigating factor with regard to precipitating or aggravating the hemorrhagic or bleeding in the bladder. No. And just as a cue of history, in the old days before hyperbaric oxygen, we used to put in very dilute formalin, which sounds pretty primitive, and it is, but it worked. It basically put a coagulum over the bladder mucosa and solved the problem. But thankfully, we've stepped beyond that.
Very interesting. Yeah, I had a similar episode 2 months ago where I obstructed from a big clot and had to spend 12 hours not being able to pee, and it was one of the worst nights I've ever had. Okay, I'm going to move on. Next, I got Norm on my list. Hi, Norman.
How you doing?
Hi, good. What's
Just
on your mind?
Nice quick update. I'm still undetectable, and my testosterone's up to 606.
Oh,
So pretty happy about that.
How's it feel?
Great. Losing weight, I can get out and work, and yeah, it's much better.
You remind me of Jimmy Greenfield because he has experienced non-detectable PSAs and high testosterone levels too.
Hopefully it stays.
Can I ask how long you've been on a holiday, drug holiday, assuming you are?
Oh, I've been off for either a year and a half. I've been off. I did I did 17 months, and I've been off since April, a year and a half ago. So, yeah, it's that I don't miss that stuff. Oh, boy.
Yeah.
Yeah,
Well,
that
is you.
good.
Right at the moment, you've got the best of everything. You've got no
Yeah.
PSA and lots of testosterone. I
Well,
hope that it lasts.
So me too.
Any comments for Norm? Any questions or comments from anybody else for Norm? I'm in a similar situation as you. I've been quite a while with a non-detectable PSA, but on the other hand, my testosterone never has gotten out of the 20s.
Ooh, well. I've been following the, I lost track of the name of this, but whatever they were doing with the darolutamide and the Orgovix, because I got an immediate response. I went from 7.25 testosterone to 0 in 3 weeks. Oh, geez. Oh man. So I mean that stuff worked on me, and they're saying the guys that got that response are doing a lot better. Yeah, PSA went to 0 and testosterone went to 0 in 3 weeks. It was might as well stepped out in front of a bus, but other than that, it worked. So
Ben has a comment for you, I think, Norman.
I do. A question, Norm. Before you went on drug holiday, how long were you on hormonal therapy?
17 months.
Okay.
How old are
you, Norman? Short.
And how old are you?
74.
Very good.
Cutting trees and splitting wood all day long, every day. Well, not every other day. I can't take every day. I need a day to recoup.
Lifting transmissions?
Oh, lifting blocks of wood 20 inches by 20 inches that are probably 100 pounds and setting them over on the splitter. Yeah.
Good job. Good job. Good job.
Very
good
good
job.
And my wife's
Great
on 80.
job.
My wife got her adaptive DBS done, and she's doing better too.
Oh, good.
And
Okay.
we always ask about her. Yeah. So she's my little AI girl.
Great.
Life's better, which is nice.
Okay, thanks for the update. Tony, you got your hand up.
Yeah, I was wondering if we could backtrack a minute on radiation cystitis.
Yeah.
I was wondering if having cauterization is a benefit or getting too much of it. I had October 3rd, 5.5 centimeter growth taken off and some other cauterization, and the bleeding is just about completely stopped, but still there, but I am on an anticoagulant. So I'm just wondering about maybe getting scoped and going in for cauterization, or maybe that's not a good idea to continue to do cauterization.
While you're on the anticoagulant, Paul, would you help me out with this question?
You mentioned the growth being resected from the bladder. Was there pathology on that?
Yes, it was not malignant or anything.
Just inflammatory radiation cystitis.
Yes, yes.
So,
and I stopped Eliquis for 3 days and the bleeding stopped. And when I went back on this week, it started up again.
Yeah, I mean, you're between a bit of a balancing act between what you need for your anticoagulation and a very susceptible organ to have bleeding, which not only is not good, it's very uncomfortable, as you've heard. But as far as repeated fulguration, not an issue with regard to any aggravation of malignancy, but obviously the bladder then begins to react, contract, perhaps get smaller. And in a small percentage of patients, you get a situation where it becomes somewhat non-functional because it's so contracted and unable to accommodate urine. But that's not common. And hyperbaric, if you have repetitive episodes rather than having repetitive fulgurations, the hyperbaric oxygen pathway is something certainly to discuss with your doctor.
Okay, thank you.
Go ahead, Norm.
Rick may yell at me for this, but I've been down this road before. You guys, corn silk tea. I see a naturopathic oncologist before my radiation. She said, just drink this to fill up your bladder. And I just made it iced tea. You can get a bag of it for £1. That'll last you a year for about $10. And it worked for me. I didn't have any problems. I don't know if she said it protects your bladder. Might help, might not, but at $10 and it tastes pretty good. Why not give it a try?
Well, I guess our feeling about that is it harmful? If it's not harmful and a person thinks it might be working, okay.
Yeah. Used to smoke corn silk. Still a lot. Of course, I mean, prostate cancer. I don't know. Who knows? But I mean,
14 years old in the cornfield after school.
Less than 14. We were younger than that. By 14, I was smoking cigarettes. Yeah.
I was going to add one other comment. One of the advantages of the hyperbaric is that heavy oxygen environment stimulates the growth of new blood vessels in your bladder. I think they call it angiogenesis, if I remember. And your current blood vessels are basically, when you have radiation cystitis, are deformed, they're leaky, etc. And it only gets worse. But with enough oxygen and enough time, you create a whole new set of blood vessels which are more robust and then behave more like a normal blood vessel. I can't speak to the other treatments, but I know this is one of the other advantages and mechanism, quite frankly, of how hyperbaric works.
Thank you, Alan. All right, I'm going to move on, guys.
We've got to move on, Tony.
Okay.
I do have about a dozen people to get to, so I'm going to move on, if that's okay. Tony, if you can contribute maybe on the chat, whatever you were going to say. And could I, Richard, ask you to unmute and tell us what's on your mind?
Okay. Oh, I just wanted to say I've gone through 2 sessions of Pluvicto. 2 weeks after the first one, I had a problem with retention and ended up in the ER, and they catheterized me. And then the next week it was all over, but ever since it's been, I've had normal urination, just drinking a lot of water. Keep it going. Otherwise,
was it a coincidence that this happened while you were on Pluvicto? Sounds like a coincidence.
That's what the urologist also said.
Yeah.
But this time I've gone through, and it's been 3 weeks since the last session, and no problem. I have a little bit of dry mouth, but I'm just zipping through it like I did with chemo.
That's wonderful. How's your PSA?
Oh, PSA is never any place. I never had a high, I never had a PSA above 2 at the beginning of all this.
So it's a worthless biomarker in your case.
Yeah, the radiation oncologist did as usual, ordered it, and the PSA is undetectable, but a useless marker.
So are you going to have a PSMA PET scan at the end of your Pluvicto or partway through?
Yes. Yep. I was told partway through, but I didn't get how far through. But
okay.
Otherwise, I'm just moving along, and matter of fact, at the second one, I got on Amazon and I bought a cheap radiation detector, one of the straight from China. And so I was having fun with the radiation safety guys. I had 3 of them in the room with me at the same time, and we're all calibrating everything. So just went right on through.
All right, great.
And I haven't heard anybody on this that really had that much trouble with Pluvicto. Am I missing that, or
guys? I guess we'll take that as agreement, Richard.
Okay. That's what I'm...
Barry. Barry, I have you next on my list.
All right, I just finished cycle number 6 here last Friday. And of course, yesterday.
Cycle number 6 of what? Docetaxel, right?
Yep, docetaxel, yep.
Yep, okay.
And so I'm in days 4, 5, and 6, which are typically the worst days, and don't have any updated new PSA. It was down to 0.12 last time.
When was that? When was it 0.12?
3 weeks ago.
Good, okay.
And so tickled pink to get through this. This has been miserable. But then I guess my question is that after this, what they typically then just put you on ADT then for some period of time after I go in December to get a PET scan at Mayo and see Dr. Heath and all that sort of thing. But I was just wondering what the kind of the next steps typically are in situations like this.
Yes, even though you might be considered to be hormone resistant, there nevertheless are mixtures of different kinds of cells in our prostate cancers, and people seem to do well if they continue on ADT, even after they're hormone resistant for a while.
Yeah, but John, he's not hormone resistant. He's just
Well, how to get on docetaxel then?
Because you had triplet therapy to begin with.
Yeah, my PSA was 435.
Oh, so your docetaxel started with all your other treatments.
Yeah.
Okay, thank you, Rick. I forgot. I don't have all my usual notes here in Canada like I usually do at home. So, okay. Yes. In that case, yes, you will continue on ADT.
Okay.
Probably for a total of a couple of years, I imagine.
Sounds good. Thank you. Appreciate
So
it.
we'll be supporting you, Mr. B, and we'll be cheering for you, and make sure you do plenty of exercise. That's going to get you feeling better quicker. Your hair's going to come back, probably going to come back curly. That happens often. Hopefully you don't have too much neuropathy. And you're into a wait and see, and let's see how we've done, and we hope you've done real well. We'd like to see that PSA go down a little bit more, to be honest, to get it down to under 0.1. But you've done real well. You've done real well. Now, the only other discussion that you might be wanting to have, and I wouldn't start it right now, but you might want to start it later, towards the end of the year, is should we be debulking your prostate? And we
okay.
seem to think that there is some value if, depending on how many metastases you had originally, and I can't remember how many you had originally. I mean, it was enough that you warranted triplet. So it will be a good discussion to have with Dr. Heath, whether she thinks it's worthwhile radiating the primary.
Okay, thank you. And thanks
Okay.
all the guys too. You guys are amazing, the information you provide.
Thank you. I'm a little skeptical that they'll go for debulking with radiation, but we'll be real interested to hear what they say. Paul, by the way, recently wrote us guys an email about that very topic. Anything else, Barry?
Nope, that's it, guys. Thanks so much.
Okay, good thing Rick was here to rescue me on that one.
Dr. John, Keith may have a voice now, but you'll have to decide if you want to take him, given how many we have. Keith, can we hear you? Put your mic. Yes. Yes.
All right.
Hooray.
Okay, my apologies. The camera, I cannot get that up at the moment, but hopefully next time.
Don't worry. So, Dr. John, I'm leaving this one up to you. That's why we pay you the big bucks.
Wow.
Yeah.
Thank you.
I really would like to continue on with some of our regulars. There's a few guys that told me that if we have time, they'll go on. So maybe those guys I can put off until next week. But I want to check in with the other regular guys, and I'm sure that we ought to be able to get at least part of your initial interview done, Keith. Let me go on to Alan.
Hi, John.
Hi, Alan.
Okay, so here's the situation. I would like to get some advice, if possible. So just to put things into perspective, this is my 4th month on apalutamide, exactly almost a day for day. And I had 2 Lupron injections. And so I've been having the expected side effects so far. But what bothers me is that as soon as I got my second Lupron injection, that was on September 25th, I had an instant drastic rise in what is called gamma glutamyl transferase, which means that my liver was out of whack, was not functioning properly. And I have to disclose here, I hope I'm not going to be judged, but I'm a heavy drinker. Okay, and on the exact day that I had that second Lupron injection, as soon as I would have a drink, I would feel nausea. And so, I contacted my team, and they basically said, we are not too sure what's going on. And I looked it up, and it's supposed to be fairly common that you get like a higher level of toxicity in your system, and your liver is going to struggle a little bit. And if you add to this alcohol, then it's going to make matters worse. So I'm a bit disconcerted that my team did not foresee that, because they know exactly about my alcohol drinking, and also I did reduce like 2/3 since these episodes, and I basically cannot drink anymore. I feel nausea, and I gag, and I even had one morning my face was all red, and I had like flushing, indicating that my liver was not processing alcohol properly. So I don't know if that happened to anybody else, or if there's anything that can be done. Of course, I can't quit drinking, but that's easier said than done. But that's kind of my situation right now. I'm kind of taken aback by the fact that I didn't see that coming at all, and nobody foresaw anything wrong with my liver, despite my lifestyle and stuff like that. So,
well, maybe your liver was in perfect shape when you started, but it's not now.
Yeah.
And I think you probably are having a combination of alcohol, hepatitis, and apalutamide toxicity.
Okay.
There's no medicine for this, as far as I can tell.
Okay.
You can get off the apalutamide and try darolutamide like we tried before, but you weren't able to get it. And
well, it's not.
I can't think of really any way that we could that you can keep drinking under these circumstances, even in smallish amounts. You know,
Dr. John, Dr. John, I'm not so sure it's the apalutamide. It could well be the Lupron.
Yeah, I mean,
I had. So you ask if anybody else has been through this. I felt, you'll understand this term because you live in Canada, Alain.
Yeah.
But I felt liverish the whole time. I felt liverish the whole time that I was on Lupron. I wasn't on another drug because at that time when I was diagnosed, they weren't giving abiraterone for, probably today I would have gotten abiraterone. They weren't giving it. But from the very start of me getting that first Lupron injection, I felt liverish. Now, for the rest of you, liverish, it means, I don't know how to explain it. It means you don't feel quite right. You feel a little nauseous. You don't. It's a Britishism, and 1 degree under is another way to say it. But I felt the whole time, and my ALT and my AST were elevated the whole time. I don't drink heavy. I did drink through it. I didn't notice there was a difference from the drinking, but my guess is, and if you look at the Lupron or Eligard or whatever, any LHRH, it is a known side effect, and there isn't a lot that you can do. I think you just sort of have to balance it out. I mean, you know, in a sense, if just the thought of alcohol makes you nauseous, that's a good thing. It's like the old antabuse drug, you know, that's how antabuse works.
Yeah.
So, but yes, it's not uncommon. It doesn't happen to everybody, but it happens to some that you do get sort of a liver reaction. And my guess is your ALT and your AST are probably elevated as well.
Okay.
We can't do Orgovix in this case. Is it unavailable?
No, it's not unavailable. It's just that I have high blood pressure, and this is why the medication I'm taking right now. That's why that's the case. That I've been prescribed the apalutamide instead of anything else. But maybe I should ask I see the doctor in 2 days, my oncologist, and maybe if we were to switch. But again, I think it's really the Lupron, because the day I got the Lupron injection, that's when I started to feel the way that Rick described.
Alain, let's not muddy the water with the apalutamide.
Yeah. Okay.
The Orgovix is an alternative. The Orgovix is an alternative to the Lupron or the Eligard, whatever you're getting. However, John, I don't know whether it's still an LHRH Orgovix, and it may not make any difference. It may be how some people process these LHRH drugs. I don't know that Orgovix is
at least it's a different drug. It's got a different mechanism.
Yep.
How it works in the pituitary has nothing to do whether it irritates the liver or not. I think both drugs are metabolized through the liver. Is that correct? Maybe Len can enlighten me about that. But still, just the fact that it's a different drug. I mean, I just don't like the sound of it. Liverish sounds cute, but hepatitis doesn't sound so cute.
Yeah. No, it doesn't. Yeah. So should I try something else than Lupron then?
I think so, if your doctor will go for it.
Can you be kind enough to type the name of the injection medication? I will ask the doctor.
There's two alternatives. Yeah, somebody will type it in for me, but there's two alternatives. One is the Orgovix and one is the Firmagon.
Okay.
You know, particularly, I don't know, what was the GGT number, the gamma GT actual
Like
number?
147.
Okay. Yeah.
Yeah, it really went up. Really.
You just might have to stop drinking until this is all over with, you know.
Yeah.
Anybody here in the room have ever have liverish feelings like that, or have abnormal liver tests when they were on treatment for prostate cancer? Okay.
Well, thank you very much then. Yeah.
Okay, write to me if you have any questions.
Okay, I appreciate it.
Len, you have your hand up.
Yeah. So Orgovix or Govix, however you prefer, can also cause elevated liver enzymes.
Yeah.
Okay.
Not sure that's going to be a worthwhile alternative. And
and
Firmagon also, you know.
Yeah. I think it's a response. That's what I was saying, Len. I think it's more of a response to the LHRH than it is to the method of administration of the LHRH. I mean, we put in 3 other drugs in there: Orgovix, Firmagon, and Eligard. They all do the same thing, but they all do them in different ways, and they're all administered slightly differently to. And Zolidux is another one that John McPhee mentions, but they all do it the same way. I think the only real alternative that you might want to discuss with your doc, with your oncologist, is monotherapy apalutamide, which is an alternative. In other words, you stop the LHRH drug altogether and you just take the apalutamide.
Okay.
That is, it's a pretty radical approach, and I think there are doctors in this country, oncologists, medical oncologists in the United States who would use that. Herb Courtney's using that right now. Doc is using it right now. David Muslin's doc is using that right now, a monotherapy ARSI. And you might want to talk to her about a monotherapy ARSI. And if it holds your PSA down, even whilst allowing your testosterone to come back and you feel better on it, it's a real alternative.
Okay, so just stop the Lupron and just stay on the oral medication.
On the apalutamide, monotherapy apalutamide is something to discuss with her. What do you think, John?
Isn't it? It's been a couple of years since your recurrence, hasn't it?
Oh, it's been 10 years. It was 2015.
No, since your recurrence.
Sorry, what do you mean?
When your PSA jumped.
I jumped like a year ago.
1 year? It's been only? Okay.
Sorry, yeah, it was in January 25.
January 25. Oh, okay. Yeah. Okay.
That's when it went up. Yeah.
Yeah, maybe even estradiol could be considered.
Yeah.
Okay.
If you really have to get off it, but.
Okay. Thank you. I appreciate it. Thank you.
John McPhee, you're next on my list, and you had just put up a question which Rick just answered anyway, but can you take the floor now?
Sure. It's just a question about apalutamide. You take it once a day, all 4 pills, and I was taking it in the morning, and by the afternoon, I was just blasted. I wasn't here. It was almost like being into my 3rd beer on an empty stomach. And so I started taking it in the evening. I take it at 7 o'clock now. And that way I'm asleep when it happens. And is that the way this works?
Doesn't matter whether it's morning or evening in terms of its effect, but it might matter in terms of sleeping through its side effects.
Yeah, it seems that I'm surprised that they make you take all 4 at once instead of 2 and 2 spread out to even it out through the day. Because if I can get through that peak absorption period, it's not too bad. I
don't see any reason why you couldn't smooth it out. Len, you think so?
I was just thinking that the fact that they recommend you take it just once a day suggests it has a longer half-life, so that even if you took it at night, I would think that the effects, including the fatigue, would hit you, for 24 hours until your next dose. It might help a little bit, I suppose, because half of that time you're asleep. But I would suggest, if you can, switch to darolutamide, which is prescribed to be taken twice a day, suggesting it has a shorter half-life. It needs to be taken twice a day, once in the evening, once in the morning, once in the evening.
Len, John's in Canada.
No good, huh?
Well, yeah, they don't, the Canadians like Alain, John, they don't have access to darolutamide the way they do here.
Okay.
I'm interested.
But Len, even if apalutamide has a longer half-life, there's still no harm in taking it. It might be that it's the course of its adverse effects might be shorter than its half-life, So if he takes half the dose twice a day, why not try it, right?
Absolutely, yeah. It certainly wouldn't do any harm.
Alain, how do you take your apalutamide? Do you take all 4 pills in the morning?
Sorry. Yes, once in the morning. Yeah, I do.
Okay.
Should I change that? Should I try?
No. I wanted to compare to John and see. And see. The thing, John McPhee, is that these drugs affect every guy differently, and so that it doesn't bother Alain. But there again, you don't have liverish feelings from taking the Zoladex or the Lupron. So this is how it does affect everybody differently. I think I would be talking to your doctor about maybe breaking up the apalutamide or taking it at a different time. I don't think we can tell you to take it at any different time or give you the authority or sprinkle holy water on doing it. I think you have to bring this up with your doctor and figure out if you can play around with the dose or take it at a different time. That would be my suggestion. But definitely bring it up with them.
Okay, my question was basically, when I switched to taking it at night, my wife's reaction was the next afternoon. She said, "Gee, it's good to have you back again."
Wow.
And I wondered what the reaction of anybody else in the group was like.
Well, nobody has done it, but I wouldn't just do it. I would talk to your docs and make sure it's okay by them to do it.
For sure.
Okay.
Well, that's, yeah.
And it probably is fine.
Yeah. Tell us what they say, because that suggests to me that there are a couple of effects that may only last 12 hours and that you can maybe exploit that a little bit by scheduling it differently if your doc's good with it.
Oh, I've already switched from morning till night because nobody seemed to care when I took it, as long as it was the same time every day.
Yeah. All right. Was that was that it then, John?
Yep.
Okay. Steve Rue.
Well, good evening, everybody.
Hello.
Well, I think I mentioned this in a previous meeting, but I had a sudden hearing loss in my left ear and some raging tinnitus actually in the right ear. Came out of nowhere. Went to see the ENT. ENT was concerned it might be some kind of a blood clot or something else pressing against the nerve because she couldn't see anything internal at all that was causing it. We did a brain MRI. That came back negative. And in the meantime, I had a talk with my oncologist. And we determined that it was extremely rare cases of some men had reported tinnitus and hearing loss taking abiraterone. So he advised me to stop taking it. And I said, well, let's don't get ahead of ourselves. We waited for that MRI report. When it came back that it was negative, we said, okay, let's stop the abiraterone. So for the last month, I've been taking only the Orgovix in the evenings. I'm still taking a half dose of the prednisone to kind of taper off, wean off of the prednisone after being on that for almost 2 years. I do have a meeting with that oncologist face to face coming up in December 6th. I recently had a couple of CT scans. The first one for bone came back looking good, no issues. Today it was the whole body. Living in a small rural area, you get a different perspective of healthcare, I guess. While I was in the waiting room waiting for my the oral what do they call it? The water you drink, the tainted water. I was waiting in the waiting room to have somebody come out to give me some of the water before the CT scan. It's got some kind of indicator in or dye or something in it. A contrast, oral contrast, contrast.
Okay.
Well, while I was waiting in the waiting room, the lady came out. This young thing came out. Must have been her first day, and she gave the oral contrast to another gentleman waiting for an MRI, which he promptly drank it. So I don't know. I don't know how that's going to help him with his MRI, but we got it straightened out. About 3 weeks ago, I was having some pretty severe back pain, and I sometimes have back pain also on and off over the decades, but maybe once or twice a year at the most. So we got an X-ray on the back, on the spine, and it looked to me at first like it could be scoliosis. And the tech said something about that too. At this time, we're not so sure that's what it is, but I did see a couple of visits to a chiropractor, and he seems to have gotten most of the pain to subside. So we're doing some adjustments with that, but there was some indication he mentioned with issues with the bone in the spine that he said looked like it could have been trauma from an injury that might have been even decades ago. I've never had any trauma like that. I don't think I have. But anyway, to make a long story short, I think we're going to be doing a drug holiday starting by the end of December. I think I'm going to just go ahead and stop with the Orgovix as well. That'll make about 3 months shy of the 2-year recommendation that Dr. Heath gave me. Currently, the recent blood work I had just last month, PSA is undetectable. Of course, so is my testosterone. So, but perhaps all that'll change around starting early next year. But that's where we're at today with Steve, with his journey with the ADT and the therapy that he's been taking for almost 2 years now. Well, actually more than two, if I count the 9 months that I was doing the injections. So the Lupron. So Lupron. Oh, it looks like we're going to have a. But I can tell you this: since I stopped taking, I mean, I don't think there's enough evidence to show causative abiraterone, causative with hearing losses and things like that. But I do know that
Yeah.
since I quit taking it, my hearing's actually improved in the left ear that went deaf, and the right ear's the tinnitus has gotten better. It's not extremely loud as what it was. I mean,
Yeah.
I'm not saying for sure that that's where I'm not saying for sure that's the culprit, but it was kind of odd that those things kind of straightened up a little bit. Of course, all of this could be related to just simply old age, right, guys?
No, not old age. I think your oncologist made a really good call there. That's a wild side effect that you had. The only way to prove it is to go back on it and have the symptom come back again, and we don't want that to happen.
Yeah, I mean, the other alternative to discuss with your GU med oncs is to switch to another ARSI, to a blocker. Darolutamide if you can get it, and finish up the last few months on that. Just a shout out.
Is that worth it to do that for just 90 days?
Hold on, please. Hold on. Just a shout out to our MS people. You're an hour early. So the MS group starts in another hour. Okay? So you may be confused because of the time change, but I see Mike and I see Louise. Come on back in about 50 minutes. Or you're welcome to stay. You can listen. If you would like to listen, you're welcome to listen. But the MS group is not going to start for about another 50 minutes, 50. Sorry, go ahead, Steve.
Well, my thoughts are if the therapy is going to be winding down anyway in March, at the end of March, what's the I don't know if three more months of a darolutamide, and I thought about that too, switching to darolutamide, but I don't know if that's really going to. I don't know. I'll talk to him about it. I'll certainly bring it up when we visit on the 6th. But I'm okay with saying, hey, it's time to wind this down and take a drug holiday, and then see. Let's see what the PSA shows for the next 6 months.
See what they say. I can't remember because I don't have my notes with me here, but were you a very, very high risk person that you really want to make sure to get that 24 months, or were you not so?
Dr. Heath was pretty emphatic about starting the clock, even though I had been on that singular path, with the Lupron injection. She thought it would be best for a full, 2 year. Yes, I was very high, 5.4 in just about all the samples, but
5+4. So she may talk you into switching to a different drug for the last few months, huh?
That could happen, and I'm okay with doing that as well. That's fine.
All right. Any comments for Steve? Oh, someone's got their hand up. Who is it? Oh, Len.
Hands up.
Yeah, thanks, John. Steve, have you taken or are you taking any of the drugs like Viagra, phosphodiesterase 5 inhibitors, Viagra, Cialis, anything like that?
No.
Okay. I just did a quick lookup for abiraterone and hearing loss, and it said it's not been reported, not known to cause hearing loss. So I was just wondering if maybe some other drug you're taking might cause it. Certainly the erectile dysfunction drugs can cause hearing loss.
I thought I knew all of the side effects of all my medications inside and out. So when I was first told that by the ENT, was the first
Oh,
person to tell me that. And I said, no, that's not right because I have all of my side effects categorized and alphabetized and everything else notarized. And, I've thoroughly studied them all and experienced all of them. Uh, but she did mention that there was some outliers out there that I think there was like 6 men in a period of 5 years or something. It was insanely like 1 in a million that had experienced the tinnitus or hearing loss. When I spoke with my oncologist, his first thought was the same as mine, that that's not a published side effect, that's not reported. But then his assistant called me back less than an hour later, and she said, "Yeah, the doctor says maybe you should stop. We did find in the UK there was like 5 incidences, and I think someplace else in Europe there was a couple. America had 3. It was so rare. It was so, like I said, there wasn't enough of it to even be able to do any kind of association or causative proof to back to abiraterone. It was just something that had come up. Um, so he said, "Hey, why don't you quit taking it?" I said, "Well, that's when I told him, let's wait for the MRI first. Make sure it's not a blood clot or something." So, but like I said, since I stopped taking it, the tinnitus has improved, and hearing, I can hear better in that left ear now than it was literally like when you're on an airplane and you're trying to pop your ears. That's what it felt like in one ear, just one ear, the left ear. It was damn strange.
let me see what
But any-
Norton has to contribute, and then I'm going to move on because of
Well,
time.
I was just going to ask the same thing Len asked, but for backache, I had to quit taking it. I had such terrible backaches. It's like, and then somebody went, yeah, I had backaches too. And I took it, like, oh, okay, I quit. And the backaches went away. So I don't know any else that had that problem.
Yeah, I noticed that was actually a published side effect too of it. So when I started having that severe backaches, I thought, well, maybe that's the damn Abby's doing that too. I don't know. But my back is a whole hell of a lot better today than it was 3 weeks ago. I mean, I was literally lying on the floor with tears in my eyes, paralyzed, but now I can, function.
Yeah, I can see why you want to get off the drugs if you can safely. John G., what do you have to bring in tonight?
This is more academic, so if somebody else needs time, they can take the time. This is more like just an academic question.
Okay, if we don't circle back to you, you can always write to any one of us
time, yeah.
moderators,
Yeah,
and we'll answer your question. How about you, Gary?
Yes, you had asked, or Rick asked last week about the number of metastases, and I've looked at my 4 radiologist reports, and there are 5 lymph nodes mentioned, and I have 3 bone mets. I do have we call it extra capillary extension, including the seminal vesicles, left neurovascular bundle, and possible involvement of the rectum, 8 millimeter node, I guess, directly abutting the rectum, but that's not been confirmed in the later imagery. So I guess the question was high volume or low volume. My treating oncologist indicates it's high volume. One of the second opinion oncologists said I was in between. I guess one question I would have is can you go from intermediate or high volume to low volume after the ADT and chemo? I have my last chemo on Thursday, and there's been a deep rapid response in the PSA, about from 90 down to 0.45 after the 4th chemo infusion. And then there was a question about the genetics. I have 5 genetic mutations that they let me see if I can find that here. I have 2 TP53 mutations and RNF-43 mutation, ARID 1A, and CDKN 2A. In addition, I have a very high PMB of 78.
Right.
In the biopsy tumor. Dr. Kwan did a wet biopsy after the 3rd infusion, and that the TMB was down to less than 5. So
we're gonna probably want to go with the one from the solid tumor, though, because as Len pointed out last time, you may simply not be shedding a lot of genetic material into your bloodstream, but
so you can go with
yeah,
either.
okay. So this boils down to that. Yes, you are high volume, right? I don't know what RNF-43 is. I'll have to look that one up for you. And ARID, you said, was a mutation?
ARID 1A is what it looks like. ARID 1.
ARID 1A. Okay. Those are not on my on my list. And then 2 TP53s in the CDK.
CDKN, I think he said.
Yes, CDKN 2A.
2A. Okay. Okay, good. You came back with all the information that.
So I think the first thing I would say to you, Gary, is that it doesn't really matter. When I say it doesn't really matter, it doesn't change your category if the metastasis we see reduces. If you were high volume in the beginning, that's the nature and how we treat you. When it's kind of weird that for whatever reason, Kwan jumped in after 3 chemos and did a liquid biopsy. I don't know why he would have done it after 3 chemos. It was a bit strange, and I don't really know what it tells us until you're finished with the course. You've had 4 courses, 4 chemo treatments so far. Is that what you said?
No, I've had 5, and the 6th one is later this week.
Okay, so that's what I was going to say to you is that, I would the protocol would be 6 treatments, and I would certainly want to finish those 6 treatments if I could tolerate it. So I think it's a good thing. And then it's much like with Barry that we got to see how you respond, and keep our fingers crossed. Some of these mutations are, not great. TP53. We don't know enough about CDKN2A and ARID1A, but our guys will know a lot about it by the time you come back next week or the week after. Because
we'll even read our next invitation about it.
Yeah. That's right. Watch out. We'll see what these are. But I really feel like you're doing all the right things. As I've said before, I don't. If it were me, I wouldn't be using Kwan. If you want another doc and you want to go to Mayo, Dr. Heath is terrific, as Barry Blomquist will tell you. We've got other great GU medical oncologists closer to Kentucky, closer to Louisville.
Yeah, you mentioned Chicago and Columbus, Ohio.
Yeah, Chicago, Columbus, Ohio. We've got some great guys. I think for us, Dr. Kwan's methods are a little too sketchy.
Okay. So can I email you for the names of those oncologists, urologists?
Yeah. We'll give you the names. And the guys on here can speak up to them. David Muslin is here right now. He'll tell you. David, you want to say something quickly about Dr. Russell?
Sure. Russell Schmulowitz from University of Chicago. I'll put his contact info in the chat. He's an amazing guy. He collaborates. He doesn't dictate, and he's on the cutting edge of everything. And he's just got wonderful bedside manner. And he's extra bright. Extra bright.
Okay, good. Thank you.
You know, and Gary, I wouldn't even make your life complicated. If you're willing to go to Chicago to see Dr. Russell, get in. If you can't get in, we'll help you get in. If not, we can send you. But if you say, look, I'd much rather go to the Ohio State, and I'm just forgotten the name of the cancer center there for a second. Maybe if you'd rather go there, we'll give you a name of somebody there. But between the Ohio State and
Chicago.
Dr. Schmulowitz, I would Montezavi is the guy we like. Mortazavi is the guy we like there. He's treated. I would rather go to Dr. Russell if it were me. But no.
Okay.
John Maxwell, you have your hand up.
I want to second Russell Schmulowitz, great doctor. He's my doctor. You can't go wrong. U Chicago.
Okay.
Now, I do have a few more guys who said to me, if there's time, I got something to say. So we could, I'm sure, put them off till next week if we want to try to squeeze Keith in. When is MS group start, Rick?
Half an hour. We need to be out the room in 20 minutes. Because we have to shut it down and then start it up again.
All right. So Keith, you want to stay a little overtime and we could get some of your initial stuff in? And that means that Dan and Dennis, whoever else I had.
But it does. It's the problem is if we start with Keith, when are we going to finish with him? That's the problem. It's tough to get halfway through somebody, Dr. John. Keith,
Keith, are you in dire straits of any sort? Are you in crisis mode or have to make a decision in the next few days?
I have to make a decision kind of soon. It might wait a week, but I think your advice, if I give you a quick overview, you might. I don't know. I don't know how the rabbit hole would be. I try to keep it brief, but I could use some advice.
Rick, if you're concerned that it'll take too much time to take on a new guy right now, I could always make contact with him out of group and make sure everything is ready for next week, and I could send Len my information.
I'm going to leave it between you and Len because Len's taking the group next week. Depends what he wants to do, and you. But I would not try to go through our whole intake form and think we can sort Keith in. I mean, we might.
Keith, what's your email?
My email is I can put it in the. It's my last name and first initial. It's Henty, spelled HENTYK @gmail.com. Henty K.
I will contact you probably tomorrow sometime. And I'll get a little history and then I will forward everything I've learned to Len and give you my first initial impressions about the decision that you have to make.
That'd be excellent. I appreciate this group. Wow, I'm glad I found it.
So I missed your email. I missed your email. Did you say KENTYK?
It's HENTYK at email.
Gmail.com. Okay. Well, we'll get you in. And thank you, John, for doing that. And because I don't want to short shrift you.
Thank you.
So
Let me just make sure that Dennis and Dan are you guys still good for waiting till next week?
I am.
Okay, Dan.
Okay.
Yeah, sure.
Yeah, and David Muslin, there's a message in the chat. I don't know if you're seeing it, Dr. John.
Robert, you have anything pressing going on right now that we can squeeze in?
No, what I have going on, you probably don't want to hear right now.
Oh, I meant the other Robert. Oh, wait.
Oh, okay.
Or are the both of these you?
No, Robert.
No,
Bogosian.
they're different.
Okay.
Okay, go ahead with the other Robert, please.
Okay, Robert B. Tell us if there's anything going on that we shouldn't wait on, please, because we don't want to leave you hanging if there is. David seems to know something about it. Could Robert speak up for David if Robert can't get his mic going?
He's not responsive, Dr. John. We'll get him next week.
Okay.
He was on, but he's off now, and we need to let him speak unless he's there. Out there, Bob Bogosian?
If you can, David, if you could make sure that he sort of comes in early enough so that we know he's there, and it's important to come in ahead of time and not right at the end. Okay.
Okay, gentlemen, it's been a pleasure. Sorry for the two guys that'll come next week. I will also get back to Keith, and then I'll get back to Len.
Hold on a minute, Dr. John. Why don't we take a couple of the people right now so we have less people next week? We've got another 10 minutes, so we may as well take.
Okay. Dan?
Sure. I got a really good or quick question. How many years can you stay on reclassed zoledronic acid? What's the recommendation?
2, I think it is. Len, can you help me out here?
Well, I'm not sure about reclassed, but for denosumab, whether it's Prolia or Xgeva, certainly they don't want you going beyond 5 years. Probably better to stop at 4. I'm not sure about reclassed. Rick, do you know?
Yeah, reclassed is zoledronic acid as opposed to denosumab, and it's really about the same thing. There are some ways to stretch it out. Back in the day, they used to give it every. Oh, Dr. Paul will remember this. Back in the day, they used to give it every 6 weeks, and then they slowly went to every 3 months. And then they figured out, well, maybe we can stop it after a few years because the half-life is so incredibly long. And but how long have you been on at this point, Dan?
Approximately 9 months.
No, you have nothing. You have nothing to even worry about at this point. I would keep. How long are you getting the reclassed?
Once a year.
Yeah, I wouldn't even. It's not even an issue to come back and talk to us in a couple of years.
Right. Is it 2 or 5? Just for my thinking.
There's nothing. I'm reading the information on zoledronic acid now. There's not a definite number of years written in here.
And it's different than denosumab, right? You have to switch. Right. Okay. Thank you.
It's just a question of probability. The longer you're on those drugs, the greater the probability that you could have osteonecrosis of the jaw.
Right.
But, there's no guarantee that you'll ever get it, I suppose.
Yeah.
Dennis, did you want to
Yes.
bring up your question?
Yeah, so it's a continuation of the back pain saga that goes on here. I had to my sacrum a repeat radiation to a different part of it that I had done before for a total of 35 gray over 5 sessions total. And my Ranox has found some information to share with me about low dose radiation for osteoarthritis. So while we're taking care of the Mets down there, I think there's probably some low dose radiation leaking out to my SI joints, and my pain has dissipated from where it was. It's not completely gone, but this is almost 2 weeks now since I finished it. So I'm not sure that's the real reason for it, but whatever's working, I'm just trying to do one thing at a time with it so I know what's working. The other quick issue was, I mentioned to you before, I had that EFDG scan done and they showed a mass in my left parotid gland.
Yeah.
And recommended to get that looked at. Well, I went and I got an MRI and then an ultrasound fine needle biopsy done. It's not prostate cancer, but it was defined in by the pathologist as a differential diagnosis. Not limited to adenoid cystic carcinoma, which is very rare. This is 1 in 100,000 people will get this diagnosis. So I'm taking this a little further, and I'm looking at looking for the best surgeon I can find to get this thing out of there pretty quick.
Is that how that particular condition is treated, with surgery?
Yes, yes.
Oh,
It's very serious surgery, and it's very difficult, and primarily because not a lot of people are practicing doing it because there isn't a large call for it like prostate cancer. But I did find a guy that I spent all weekend, Saturday, Sunday, basically searching information and educating myself about this parotid gland tumor, because they initially thought it was a Warthin's tumor, which is a benign tumor.
Yeah. It's a good thing you looked into it further. Is this a malignancy that can metastasize or invade?
Yes, even if it's not, there's other components to it. There's also a pleomorphic adenoma.
Yeah.
And salivary gland basiloid neoplasms and more. And it's not limited to that. So it definitely needs to come out. It does look like it's a low grade, my untrained ability here. I really have not had a discussion. My doctor that I saw, the otolaryngologist that ordered this thing and this testing, the MRI and so forth, just failed to call me. We had a meeting scheduled with him for the day after. Apparently, he didn't know that the lab takes more than 1 day to get this analysis done.
So, Dennis, what is this again? A parotid gland?
Parotid gland, yes. Parotid gland and salivary gland.
Okay, salivary. So this is in the salivary gland.
Yeah.
And they don't think it is related to the prostate cancer?
Correct.
Okay, so my question would be that does this express PSMA? Does the parotid gland express PSMA?
The salivary gland, Rick, you can't see. The salivary glands always light up with PSMA PET because that's the physiological expression. So it could be blinded from a PSMA PET, but the FDG scan showed the mass. And then the
Okay,
MRI,
so the parotid gland does not express PSMA, but the salivary glands do express PSMA.
it's in the salivary gland.
Parotid is a
Parotid
salivary gland.
tumor in the salivary gland.
Okay, okay.
We are hearing about some pretty rare conditions and side effects tonight, aren't we?
But it just threw another curveball at me to have to chase down.
Yeah.
I would think that the fact that it's picked up in an FDG scan suggests that it's fast growing because.
Yeah, it was Len, it was a 40 SUV.
Okay.
That's pretty high.
Yeah.
But typically the type of tumor is supposedly not fast growing. And like I said, it's just under 2 millimeters, centimeter. I'm sorry, 2 centimeters in size, and that means it's a superficial and potentially low grade.
Can you feel it?
I can feel it. I'm sore now just from the biopsy. They did a fine needle aspiration, 5 cores, 10 slides. And this is really crazy. What drives me nuts is not being able to get an explanation from somebody that supposedly knows all about this stuff. This doctor that I went to never even called me. So I've sent messages to him. I'm ready to change docs in midstream and go to Mayo Clinic in Rochester, where this other Dr. Eric Moore is about the most expert person I can find in the country. So I'm in the process of trying to do that.
Okay, I just want to get John G's question into Dr. John, because we sort of we swung straight over the top of him. And John, what's your academic question that you had?
I just saw Scott Adams is being treated for prostate cancer, and they're treating him with something called Anktiva. Pluvicto and Anktiva, and it's a BioShield. Apparently, it's like an immunotherapy, and I was wondering if anybody had heard about it. It's I guess it's kind of bleeding edge stuff. Well, they use it with other cancers. They use it with other cancers, just not prostate cancer yet.
Yeah, I haven't read anything about. He's at Kaiser, so I have not read anything about any drug other than Pluvicto. If there is another drug, I doubt that he's getting it from Kaiser, unless he's in a trial.
I think it's the the administration did an intervention or whatever, RFK, and they got him on to kind of a compassionate thing. So I was just wondering if anybody heard about it or if anybody knew anything about it. It might be interesting for people to look into too. Anktiva, and it's called BioShield. Is, I guess, you can Google those things.
Well, who knows if it's something that RFK is recommending? Who knows whether it has any validity for prostate cancer? But BioShield, and what was the name of the drug?
Anktiva, Anktiva. It natural killer cells, because it promotes immuno and boosts your immune system.
Okay, well, maybe that and a dime will get you cured.
Right, it's in there with fenbendazole, right?
Yes, I don't know, but I wouldn't be surprised if it is in with fenbendazole. But the Pluvicto may have an impact, but I don't know anything about the BioShield Anktiva. If somebody wants to research it, let us know next week.
Well, gentlemen,
anyway, thank you guys very much.
We're going to clear the room and let Rick restart the program.
Thanks, everybody, and Keith. I'm sorry that we didn't get you. Dr. John will talk to you, and we will do a full. Len will put you up first next week for
Okay,
as
thank
a new gent, and Dr. John will
Thanks very much.
brief Glenn on that. So thank you, everybody.
Everyone, good
Good
night.
night, everybody.
Thanks, John.